I appreciate the opportunity to be here. It's always exciting to be able to talk about new developments in spine and the different options that are emerging over time. I went into spine in the beginning because I had a really uh, charismatic mentor that was always very passionate about new developments in spine and how it was such an evolving field. And he's been right. It's been kind of a whirlwind of new developments, and things have come and gone, but the good things persist, and those things just continue to help patients, and the bad things that don't end up working don't stick around very long. So TOPS is, in my opinion, is going to be one of those things that stands the test of time, and the studies are showing that. So I'm excited to be able to incorporate that into my practice here in Utah.
Great. Well, thank you. Great introduction. Um, I'm always interested, especially from orthopedics, why spine versus, either general ortho or sports or other. So it's a good explanation. I appreciate that. So when did you first become aware of the top system? And what drew your interest into it?
So that's a good question. So every year, to maintain our board certification, we have to read a certain number of articles that we choose from a certain list from the American Academy of Orthopedic Surgeons. And on the list this last year was the IDE trial that was actually done with my former mentor, Dr. Ahmed Nasser at the Mayo Clinic. So I recognized that name on the paper, and I thought, well, this is kind of interesting. I know this guy. Let's see what he had to say and what he's been up to. And so I read the paper. It was on TOPS, being a motion preservation alternative to fusion. And it was a great paper. I was really interested in it. I read it a couple of times that first night instead of just the once that I had to, and answer a couple of questions to get, board certified. But it was an interesting paper, and it really got the gears spinning in my head. And I did a lot more research on it, and finally reached out to the rep to see if that would be something we could get on contract at our hospital to start offering in this little town up here in northern Utah.
Very good. Very good. So, um, when evaluating tops like that and really understanding the data, I'm glad that the data is what convinced you first. Um, sometimes we look at the technology itself and get convinced that motion preservation is a good thing, which it is. But the unique thing about TOPS is the strength of its data. That's
Mhm.
And when you look around spine, because of the prevalence of 510(k) technologies in spine, it's a bit rare to have a technology that has such good data that we ran an IDE and you had a randomized controlled, clinical trial, especially with a superiority claim to the gold standard of fusion. So, um, in that, then, so what gaps or unmet needs? Then obviously, I'm assuming TOPS filled that, right? So, what gaps or unmet needs did you have in your armamentarium or your practice that drew you to TOPS and that now TOPS fills for you?
Yeah, that's a good question, Jeff. So one of the biggest problems I see in spine surgery is the problem of adjacent segment degenerative change.
Mhm.
A one-level decompression infusion it's a great treatment for patients with grade 1 degenerative spondylolisthesis, back pain, and neurogenic claudication pain. It's a great operation. However, it tends to break down over the years. Over 3 to 10 years, we see the adjacent level start to wear out. And so I'm always looking for an option that will hopefully eliminate that problem or at least reduce it substantially so the patients don't have to come back in 5 or 10 years for revision surgery. And that was my main driver to adopt the TOPS over doing a one level fusion for this condition.
Hmm. Interesting. So now that you have TOPS and you've done some cases and now you're expanding your utilization of TOPS, what particular patient profiles or pathologies do you feel so far best suited for TOPS?
Yeah, so the best patient for a TOPS would be a patient with grade 1 degenerative spondylolisthesis. It needs to be a symptomatic problem that's going to require a wide decompression. This patient usually has facet joint degeneration. The segment that we're evaluating has to be mobile. So in other words, it can't be so arthritic that it has no motion. There has to be a disc that's reasonably maintained its height. It doesn't have a large disc herniation associated with it. There needs to be good bone quality. So a patient with severe osteoporosis probably wouldn't be a good candidate. And also a patient with no major scoliosis or spinal deformities. And these patients are typically going to be on the younger side, although I've done these operations in older patients as well, and they've done extremely well. In my experience, the patients that we've done TOPS on tend to get better faster. They return to clinic a little more mobile, less pain, and it's been remarkable in my experience compared to even a one-level fusion versus TOPS. And so I typically see these patients as being motivated. They've done a lot of research. They know what the options are. They don't want a fusion for good reason, and those are the patients that are good candidates. Now, we want to avoid a TOPS in somebody with more than grade 1 spondylolisthesis or a significant deformity or scoliosis, severe osteoporosis. We can't have multi-level instability, meaning more than one level of spondylolisthesis. There are some occasions where you might do a combination fusion and TOPS in that scenario, but I'm still waiting for the 2-level TOPS to come out.
Well, we can talk about that.
But the success of TOPS is really highly dependent on selecting patients in a very stringent and very strict. You want to have the right conditions to have a patient do well with TOPS.
Well, so that you've kind of beat me to the punch on my next question. So we talked a little bit about where it may not work and where you might be contraindicated based upon certain pathology. What types of patients are you seeing that you feel or predict especially good outcomes? So I'm assuming not osteoporotic, grade 1 spondy with a healthy disc and that type of thing.
We try to avoid doing elective cases on patients with uncontrolled diabetes. We encourage, hemoglobin A1C below a certain number to help prevent infection. We want to try to encourage weight loss that improves mobility postoperatively. We like to advise against smoking, so that also helps with wound healing. But essentially, anybody who's a good candidate for a fusion could be a candidate for TOPS. Now, I say could because not every patient who is a candidate for fusion is a good candidate for TOPS. I think the one important distinguishing factor is to be a good candidate for TOPS, you have to have severe stenosis that isn't coming predominantly from the disc. It has to be mostly from hypertrophic facet joints and ligamentum flavum without disc herniations. Our disc has to be fairly good to proceed with TOPS.
Yeah. So what post-op outcomes have stood out to you since integrating TOPS into your practice? I guess especially as it relates to fusion. I mean, are you seeing any differential post-op outcomes that stand out to you?
Yeah, definitely, Jeff. The one thing I've noticed is most patients aren't requiring as much pain medication post-operatively. They're able to leave the hospital just a little bit sooner. They're not as sore when they come back for their 2-week post-op. They're much more comfortable in walking in easier than they are with a fusion. And that has to be due to the maintained mobility of that level and the soreness that fusing a level creates. I think that's what it is.
Yeah, that's really interesting because there's a lot of conversation about muscle sparing, when we talk about, MIS treatments and things and you think about the level of incision required for TOPS. I mean, it's not a percutaneous procedure by any means. And so that's really encouraging to hear that the recovery is good and it may be a little faster than fusion.
Sure. It's been surprising because I do essentially the exact same incision for a 1-level fusion as I do for TOPS. It's the same length incision, almost exactly as much dissection of the soft tissues over the spine, with the exception of in TOPS, I don't have to dissect out as laterally as far, because in a fusion, we have to dissect out laterally to be able to put bone graft over those lateral areas. And of course, with TOPS, there's no bone graft to be placed, so we don't have to dissect quite as far laterally, but it's fairly insignificant, the amount of difference in the incision and exposure that I do for tops versus fusion.
And so as it relates to patient mobility, I think you mentioned a little bit about that, but as it relates to patient mobility, once again, compared to fusion, are you seeing patients more mobile faster, or that's one question. The other is, or increase in total mobility as it relates to fusion, or is it close to the same?
I wouldn't define the improvement in mobility as in actual magnitude of range of motion,
Yeah,
inflection, extension, rotation. It's just the comfort with which they walk into clinic. They're up and around easier. They're moving faster. They're not as uncomfortable.
that's great.
And in that sense, they're more mobile. Mhm.
Yeah. And we're going to move to Q&A here in a moment. I'll ask you one more question. You touched on this a little bit earlier, but I wanted to have a follow-up question. As it relates to the biomechanic impact of utilizing TOPS versus fusion, especially its impact on the adjacent level, um, I think that's a really interesting topic for people who might not be as familiar with fusion and um, what fusion, not only what it does, but also what it can trigger, and a bit of a cascade of events that can happen from that. And sometimes that's unavoidable, but I'm interested in your perspective on just the biomechanic differential between TOPS and fusion, and your speculation on the treatment of not the treatment, but on its impact on adjacent segments.
For sure. When you connect one mobile motion segment together, one consideration is fusion tends to reduce the lumbar curvature. We call that curvature in your lower back lordosis, and that curvature is, you can think of it as a C shape. And so fusions just tend to straighten out the lumbar spine just based on some of it's surgeon technique, some of it's the implant position. And when 5, 10, 15 years ago, surgeons didn't understand as well the importance of restoring normal curvature and lordosis. And so that's one effect. And reducing that curvature can transfer more of the stress that you would normally be getting through that motion segment. Let's say we fuse 4-5, more of that stress that you would normally be putting through L4, L5 has to be transmitted up to L3, L4 and L5S1. So those discs essentially are working harder. They become hypermobile, and that causes the disc to wear out faster. That causes more facet joint loading and degeneration, which accelerates the stenosis. So it's sort of a domino effect at the levels above and below the fused level.
Yeah.
TOPS eliminates that because, well, it doesn't eliminate it, let's be honest. It probably reduces it, and that's what the studies are showing.
Right.
The clinical outcomes are showing that there is a reduced risk of ASD or adjacent segment degeneration, but I don't think any operation or intervention can reduce it to zero, but it does allow for continued motion at the operated level, which reduces the transmitted stresses above and below and helps protect those structures from accelerated wear and tear.
Yeah, absolutely. Great answer. I appreciate it. Well, let's jump into Q&A. We've got several questions here. Um, I will, some of these you've answered already or touched on a little bit, so I want to be careful with being redundant, but there might be points of clarification here that are important. Here's a question. And forgive me as I read through these while I'm asking. Is the TOPS procedure appropriate for L4, L5, 6 millimeter anterior listhesis, resulting in severe right neuroforaminal narrowing, moderate to severe left neuroforaminal narrowing, and moderate to severe spinal stenosis? If so, does this put added stress on L3? Did you track with that?
Yeah, just from what is described by this patient's questions, I didn't hear anything about disc herniations. It sounds like an ideal candidate for a TOPS. The decompression of the foraminal stenosis, which was severe on the left and moderate on the right, would be taken care of by removing the entire facet joints on both sides. That's what we call a facetectomy. Anything in medicine with ectomy is to remove, like an appendectomy. So in a facetectomy, we're removing the facet joint. And as you remove the facet joint, that forms the roof over the neural foramen. So then you can access and clean out around the nerve root on both sides, and fully decompress that. The 6 millimeter spondylolisthesis sounds like a grade 1. A grade 2 would be more something along the lines of 10 or 12 millimeters. So we're well under that. As long as the disc space is relatively well maintained and your bone quality is good, I would assume that you may be a good candidate for TOPS.
Great.
And it is indicated for L4, L5. It's indicated for L2 to L5, the exception being L5S1. It's not been studied in at that level, and so it would be L2 to L5, and that fits within that range.
Correct. Okay. You touched on this a little bit, but I want to clarify something. Does this work for lumbar radiculopathy, or disc degeneration or disc displacement?
That's a really good question. And lumbar radiculopathy and nerve pain are interesting because those can be caused by spinal stenosis. If it's being caused by central canal stenosis, we can certainly do a laminectomy and decompress those nerve roots. If we have a patient with radiculopathy that's due to a big disc herniation, on the other hand, in my practice, if there is no spondylolisthesis, I would do a microdiscectomy on that patient. Personally, I wouldn't do a fusion or a TOPS. But if there is a disc herniation associated with a grade 1 spondylolisthesis, then I guess it would depend on how big the herniation is, what the remaining disc looks like, and that would be my treatment kind of algorithm and looking at those things specifically. I know that's a little bit of a gray answer, but without seeing the imaging, it's a little tough.
Well, some of these questions are hard to answer in that regard, and I think you point out a really important piece of this is that, and we don't talk much about it, but I don't know what percentage of the total time you spend diagnosing a problem versus fixing the problem, but it's just understanding source of pain, right? Whether it's vertebrogenic, discogenic, stenotic. I mean, really, where's the pain? Where's the pain generator? You spend a lot of time figuring that out first before you decide what to do about it, right?
Correct. Yeah.
Yeah.
Mm-hmm.
So it makes a lot of sense. It's a good question. So here's one that sounds like someone's maybe about to have a TOPS procedure. Since I'll have to travel for surgery, what's the post-op recovery specifically with respect to travel by car and by plane? How many days post-op most likely can 2+ hours be tolerated in a vehicle, or 3-hour flight be possible in a certain amount of time?
That's very patient dependent. I'm okay with my patients traveling after a fusion or a TOPS, essentially when they're discharged from the hospital, as long as they've got adequate pain control. They're not driving, of course, hopefully. I counsel patients to get out of the car every hour and just walk around for 5 minutes to help prevent DVTs or blood clots. For a TOPS, I don't require the use of a back brace, so that's a little less restrictive as far as traveling goes. The only restrictions I put on patients would be no lifting more than about 10 to 20 pounds for 6 weeks. I encourage them to continue to twist and bend, which isn't the case for a fusion. Fusions, no bending, lifting, twisting, and they wear a back brace for 3 months. But traveling wise, they could, I think, comfortably travel probably about, I would say, 5 to 7 days after surgery on a plane. In a car, you could manage a couple of hours, 2 or 3 days post-op.
Got it. Here's another one. I had a 4-level lumbar laminectomy in 2019. Can the TOPS device be used in this area for decompression? I'm looking for options other than a 3-level fusion. So I'm assuming there's been some progression since the laminectomy in 19 to potentially require the next step.
Definitely. So a TOPS could be indicated in a patient that has had a previous laminectomy. If there's been progressive development of stenosis, particularly foraminal stenosis, probably in this case, or even recurrent central stenosis, that can be addressed with a revision laminectomy and revision decompression, followed with the posterior stabilization that TOPS would provide. Now, that could be done at 1 level, potentially the worst level, I guess, quote unquote worst, or it could be combined with a 1 or 2 level fusion and a TOPS if you were requiring a 3 level procedure.
Makes sense.
And I would potentially do the TOPS at the upper level, the top one, to try to prevent the adjacent levels from going up higher.
Well, and there is a question in here. I went by it a moment ago. I was looking for something around um, can you perform tops at the adjacent level above a fusion?
You
Um,
can,
yeah,
yes, yeah. The success of that might depend a little bit on the placement of the previous pedicle screws. If they're reasonably well placed, then we'd have to remove those, of course, but there's still a hole where the screw used to be. And we'd have to put new screws in at the new level and the old level. And when I do these TOPS procedures, my goal is hardware perfection. I want perfect alignment and perfect placement of those screws to maximize the mobility of that implant. Because one of the ways this can fail is malpositioning of the TOPS device itself. And so if those lower screws led to me feeling like that implant would be malpositioned, then maybe not. But if they're reasonably well placed screws, then yes, you could change or do a TOPS above a previous fusion.
right. And there was another question, just a bit related, but if I had a TOPS procedure and for some reason it didn't work or it failed, we haven't really seen that, but could that level be converted to a fusion?
It could be. In fact, that would be quite easy because the screws are there. All you do is remove the TOPS device and place 2 parallel rods and do your bone graft work. And essentially the fusion that's the only technical difference between the 2 operations.
Yeah, that's one of the real benefits. Um, to a certain degree, we don't really see that, a conversion of TOPS at this point. But it's you're right. It's pretty
It
easy
could be
now.
done.
Here's another one. I'm a healthy 79-year-old woman with level 1 spondylolisthesis and advanced osteopenia. I have radiculopathy in the L4, L5, S1 region. Am I a candidate for TOPS?
That's a really good question. And some of this would depend on what the bone density test revealed, what your bone density T-score, we call it, the DEXA scan. Osteopenia itself isn't a relative contraindication to the TOPS. Severe osteoporosis, however, would be. So if you were my patient, I would try to treat you with 6 months to 12 months of osteoporosis treatment and try to build up some bone density. And then we repeat a bone density test, and with improved bone density, then we proceed with either a fusion or a TOPS. But with severe osteoporosis, we're at risk of doing a fusion or a TOPS. Anything that requires hardware or these screws that can pull out of soft or osteoporotic bone. So my counsel would be to treat the bone density first and then do the procedure.
Makes sense. Let's see. Another question here. L4, L5, severe canal stenosis and moderate right and mild left neuroforaminal stenosis with anterior listhesis, disc bulge, severe facet hypertrophy, and am I a candidate for TOPS?
It sounds that you may be. Now, disc bulge, and when a radiologist describes a disc bulge in a report, that can mean a wide variety of things. It could be a huge bulge or a very small bulge. And most discs over time do bulge or protrude just a little bit. What we don't want to see is a big disc herniation or extrusion. So if we have a disc bulge, it's probably contained, and that could definitely be amenable to a TOPS.
Okay. Oh, here's an interesting question. How much does TOPS device protrude from the spinal area? So if I had this procedure, would it be awkwardly noticeable when wearing pants or lying down?
That's an interesting question. When I first started putting the TOPS device in, I was sort of surprised at how big the implant is. It's a fairly robust chunk of metal, to be honest. But but when you put it in and it's all in place, it doesn't protrude any higher than the normal spinous processes, which are the little pokey bones you feel in your back. When you feel back there, you feel those little pokey bones back there. Those are called your spinous processes. So this implant is actually below that level, and it's fully contained, covered by muscle and fascia. And when the skin is closed, you can't feel it under there. I've felt my patients' backs. I can't feel it. It's smooth. They don't feel pain when I press on it, and you wouldn't even know it's there when you have your pants on. You could wear whatever you like.
Great. Well, it looks like we've got one more minute, time for one more question. Let's see, and this is a good one. So the question would be, how do I pick a surgeon to perform the TOPS procedure, especially if I have no way of knowing how many times they've performed that procedure and their success rate?
Yeah, that's a really interesting question. And I guess the answer I would give you is it's a fairly new device. It's a new technology. So there probably aren't a whole lot of surgeons that have done a very, very high number of these cases.
Right.
Everybody, like myself, we all have to start with case number one. And from that case, we build our confidence up, we get good at the procedure. So I think overall, you'd have to ask your surgeon, have you done any of these? Have you done a few, less than 10? I personally have done about 10 of these. I'm probably the only one in northern Utah or this area doing it. And I would be doing more if insurance authorized them more freely. I think more important than the number is I would look at the characteristics of your surgeon. Look at their general outcomes for fusions. Look at their outcomes for cervical disc replacements. Look up their reviews on bedside manner, how meticulous, how careful they are, what's their infection rate, because those are the underlying skills that we all have to develop that all translate to doing a TOPS procedure, and they translate well. And so if we're having success in these other areas, then I would be able to interpret that as they're probably going to be capable of doing a TOPS successfully, even if they've only done 5 or 6 or less, if that makes sense.
Yeah. Well, and I don't, you're much better to speak on this than I am, but the majority of the TOPS procedure is very similar to a fusion procedure. Until sizing the device and putting it, I mean, there are some differences, but pedicle screw placement, gaining access. I mean, a lot of that, the wide decompression. I mean, there's a lot of it is similar to the initial steps of your fusion procedure. You're just not fusing.
That's definitely true. Yeah, it's essentially a very, very similar operation. If a surgeon's done a fusion, they can do a TOPS. The only difference, I think, is that you have to just be quite a bit more picky, we'll call it, or stringent on your perfect placement of your pedicle screws.
Yeah.
If you're doing a fusion, it doesn't matter if your screws are not quite parallel or if one's going up and one's going down. But in a TOPS, we just want to make sure those pedicle screws are just perfectly placed. And it's not hard to do. It's just the surgeon has to be cognizant that that's what they want to do in that scenario. And if they've done the training, then that's something that the TOPS people at Premia Spine definitely communicate with the surgeon at a time.
Yeah, absolutely. Well, listen, this has been great, Dr. Vernon. Thank you for your time. I really appreciate it. You did a great job. Really explained a lot of things very well. For the attendees, if I didn't get to your question, I apologize. We ran out of time. You will, if you want further information, you'll receive an email, and when you leave this webinar, there's a survey for you. So there's plenty of opportunities to contact Premia Spine through our direct-to-consumer department, and you can be connected to surgeons according to where you are across the country, or if you're in Dr. Vernon's area, I'm sure he would love to be able to talk to you. We appreciate you attending tonight. Hope this was informative for you. And once again, thank you for taking the time to join us, taking control of your care and investigating more and more about this type of technology. So, Dr. Vernon, thank you again. Really appreciate you. Appreciate your time.
Thank you.
You did a great
Thanks to all
job.
who attended. That's great that you're so fully invested in looking at new developments and options for your spine care. That's great.
Very good. Thank you. Have a good evening, everyone, and we'll talk sometime soon. Take care.